Hello, and welcome to this presentation about knowing how to deal with acute spinal disease in dogs and cats. First of all, it is crucial in every single case to perform a physical examination to start with. There are many systemic disorders that can give rise to clinical signs that may potentially look like a neurological disease. Dogs and cats with, let's say, anemia or abdominal discomfort or heart disease may potentially present with signs of obtundation, tetraparesis, or collapsing episodes that can look like seizures. Assessing some easy parameters like the color of the mucous membranes or the paw pads, auscultating the thorax, palpating the femoral pulses, or checking the temperature may help us easily suspect some of these conditions. A very important part of the hands-off neurological examination, especially when we talk about spinal diseases, is the assessment of the gait. And in neurology cases, there are two very important things of the gait that we should assess. One is the voluntary motor function, a movement, and the other one is coordination. Not very frequently, but in some cases, some neurological disorders may display lameness as well. So if we talk about voluntary motor function, and when we have a decrease voluntary motor function, we say that this animal is paretic, or we have paresis. A paretic animal can still be able to walk, in which case we will have ambulatory paresis, or sometimes this weakness, this paresis, is too severe to allow them to walk, in which case we will be talking about non-ambulatory paresis. When there is no voluntary motor function, we talk about plegia or paralysis. And when we have plegic animals, we should assess pain perception or nociception, so ability to feel pain with the forceps squeezing the toes, for example. Hence why we only assess nociception in spinal disorders when we have animals with a plegic limb. If there is paresis, we should not check nociception. And then we use the prefixes mono, hemi, para, and tetra to say which limbs are affected. Talking about coordination, and especially when there is a decreased amount of coordination, we say that this dog or this cat is ataxic. Most spinal diseases, if they have ataxia, it'll be proprioceptive ataxia. But as you know, there's two other types of ataxia, which are cerebellar ataxia and vestibular ataxia. As I said before, and this is not common, cases, for example, of foraminal disc extrusions or discospondylitis or degenerative lumbosacral stenosis may present with lameness, normally as a result of nerve root signature, but this is not common. Getting into more detail, if we talk about the neurological examination, it is very important to differentiate signs of upper motor neuron and lower motor neuron disease. So, talking about anatomy, the upper motor neuron cell bodies are within the brain, and these neurons are responsible for three things: initiation of voluntary movement, maintenance of muscle tone for support against gravity, and also the regulation of posture. This upper motor neuron activates or inhibits the lower motor neuron, which is the neuron in contact with the muscle. These cell bodies are in the cervicothoracic, as you can see here, and in the lumbar intumescences. Hence why the clinical signs of the neurological dysfunction that we will have in cases of upper motor neuron will be very different, or will be different from lower motor neuron cases. Proprioception or postural reactions can be decreased or absent in both instances, but as you can see, the spinal reflexes and the muscle tone will be either preserved or increased in cases of upper motor neuron disease, and they will be reduced, absent, or really decreased muscle tone when we have diseases affecting the lower motor neuron system. If these animals have muscle atrophy with upper motor neuron disease, normally this muscle atrophy is as a result of disuse, so it'll be slow and mild. However, if we have a lower motor neuron problem, this muscle atrophy will be neurogenic, hence it will be quick and severe. So after having done this examination and having deficits in some limbs, and depending on the type of deficits that we have, we will be able to tell where the lesion is within the spinal cord. And as you know, we have 4 spinal cord segments, which are C1-C5, C62, T3-L3, and L4-S3. So when we have a C1-C5 spinal cord problem, it's very likely that we have upper motor neuron signs in all 4 limbs. When we have a C62 disease affecting the spinal cord, the deficits in the thoracic limbs will be typical of a lower motor neuron disease. So we may have decreased proprioception, but we will also have a poor muscle tone. We may have decreased reflexes in the thoracic limbs, but in the pelvic limbs, we will still have an upper motor neuron presentation. With a T3-L3 and an L4-S3 myelopathy, we will have normal thoracic limb function, although we will see a couple of exceptions in just a few minutes. But in the pelvic limbs, it'll depend. If it's a T3-L3 myelopathy, we will have preserved spinal reflexes, although we may have absent proprioception. However, if we have an L4-S3 spinal cord problem, we will have a poor muscle tone, we may have atrophy, and we will have decreased proprioception in the pelvic limbs. It's important, especially when we talk about spinal cord diseases, and even more so in an emergency setting, to grade neurological dysfunction, because this will tell us a lot, as we will see later, about prognosis. There are different classification systems, but this one is very simple and helpful. We have 5 grades, from the mildest, 1, in which we have no neurological dysfunction, but we only have spinal pain, to the most severe one, which is 5, in which we have paraplegia, so inability to move the limbs voluntarily, without nociception, without pain perception. So when we talk about acute spinal cord diseases, and this is kind of an exception of what we've said 2 slides ago, it is very important to know a syndrome called spinal shock. This is a condition seen in acute and severe thoracolumbar myelopathies. These patients that normally have a T3-L3 myelopathy, if we are correct, should have preserved spinal reflexes in the pelvic limbs, because the spinal reflex arc are anatomically spared. But these dogs may exhibit transient hypo or areflexia causal to the lesion, again in a T3-L3 myelopathy. In dogs and cats, spinal shock is generally considered to be short-lived. However, there's evidence that pelvic limb withdrawal reflexes may be decreased for periods of 12 to 48 hours. It's mostly associated with ischemic myelopathy, so vascular accidents in the spinal cord, but we see it as well very frequently with acute disc disease. Another abnormal and very distinct and characteristic posture is the Schiff-Sherrington posture. We may see this in thoracolumbar or in cranial lumbar myelopathies, and this happens to a disruption of the ascending tracts that inhibit the thoracic limb extensor muscles. Therefore, the result is an extensor hypertonia of the thoracic limbs, as you can see in the dash shown in the picture, with flaccid paralysis or severe paresis of the pelvic limbs. This is seen when dogs are in lateral recumbence, because when they are held on a standing position, there is normal motor function in the thoracic limbs, hence normal proprioception in the thoracic limbs. Schiff-Sherrington posture is merely an anatomic phenomenon and does not connote anything regarding prognosis for return to ambulation, which happens exactly the same with spinal shock. So there is no prognosis associated with the presence of Schiff-Sherrington or spinal shock. It just suggests severity. So after having done our neurological examination and taken a good clinical history, automatically our differential diagnosis will narrow down. taking into consideration the most common conditions that we can see in each breed, species, and age group, will also contribute to approach each case accordingly. It is very important to remember the temporal behavior of each etiology to come up with our differential diagnosis. For example, vascular diseases are peracute in onset, and neurological deficits tend to be quite drastic and dramatic to start with. With time, though, clinical signs tend to stabilize or even improve with no specific treatment. And this is completely different if we compare it to how neoplastic or some degenerative diseases behave. In these cases, the clinical signs will likely be chronic, long-standing, and slowly progressive. So, the first disease that I'm going to talk about is steroid-responsive meningitis arteritis. This is a condition seen in puppies or in very young dogs. Although it may happen in many breeds, there is a strong breed predilection, with beagles, boxers, Weimaraner's being overrepresented. Since the disease does not affect the spinal cord parenchyma, neurological deficits like paresis or ataxia are not seen. Instead, the most common clinical signs are rather systemic, and these include neck pain, lethargy, fever, and anorexia. Blood work can help to increase the suspicion of steroid-responsive meningitis arteritis if we see clinical pathological findings suggestive of acute inflammation like neutrophilic or even monocytic leukocytosis, hyperglobulinemia, or hypoalbuminemia. And a very useful biomarker is the C-reactive protein, which is very sensitive but also unspecific, so it can increase in any inflammatory disorder. For this reason, simple imaging of the spine may help us rule out other causes of severe neck pain and pyrexia, like for example, discus spondylitis or even atlantoaxial subluxation or fractures. In order to further support the diagnosis of SRMA, cerebrospinal fluid analysis should be performed and should confirm the presence of pleocytosis with a predominance of neutrophils, as you can see in the right bottom picture. In warm countries with prevalence of vector-borne diseases, this should also be ruled out. So, since we're dealing with an immune-mediated disease, the cornerstone of the treatment is immune suppression, and this is successfully achieved in most cases with corticosteroids, initially at immune suppressive doses, and then gradually dose decrease should be done upon clinical examination and C-reactive protein monitoring. Auxiliary immune suppressive drugs like cyclosporine, azathioprine, and even cytarabine are not normally required. The prognosis is good in most cases, but we can see relapses, especially if the dose decrease of the prednisolone is too quick or if the duration of the treatment is too short. Intervertebral disc disease. So this is a broad term that is widely used in veterinary medicine and encompasses a range of lesions affecting the intervertebral disc. The intervertebral disc plays a critical role in stability of the vertebral column, effectively binding individual vertebrae together to provide support for the entire axial skeleton, while allowing multiplanar movement. There are three main parts: the nucleus pulposus, that we can see here, which is a gelatinous bean-shaped mass that sits slightly dorsally within the intervertebral disc. Then we have the transitional zone that represents the transition from the nucleus pulposus to the annulus fibrosus, and finally the annulus fibrosus, you can see here, which consists of inner and outer regions that are both characterized by concentric fibrocartilage lamella. So the first type of disc disease is intervertebral disc extrusion, or intervertebral disc herniation Hansen type 1. This consists of a chondroid metaplasia and calcification of the nucleus pulposus, which ultimately results in a type of intervertebral disc herniation whereby the calcified nucleus pulposus acutely extrudes through a ruptured annulus fibrosus into the vertebral canal, causing spinal cord compression and, in many cases as well, contusion. Chondrodystrophic breeds are more commonly affected, although it may happen with any breed and pretty much at any age. Neurological dysfunction may be variable from plegia with absent nociception to only spinal pain, and every single spinal cord segment can be affected from the neck to the lumbar area. Simple radiographs and routine blood tests are unlikely to be relevant in the diagnosis, and most of the cases what we need is advanced imaging like MRI or potentially CT or myelogram. How can we treat these cases? So we can treat them conservatively or surgically. To treat these cases conservatively, what we should do is instigate street cage rest, potentially up to 8 weeks, because this is the time that the annulus fibrosus requires to heal up. It's important to provide patients with multimodal analgesia using non-steroidal anti-inflammatories, potentially gabapentin, paracetamol, opioids the first few days, or a combination of them. And these will depend on the intensity of the hyperesthesia pain that they may have, and potentially as well on the side effects that each individual dog may have to certain medications. Pharmacological and even manual bladder management is required, especially in non-ambulatory patients. Physiotherapy and hydrotherapy will likely help as well, especially in cases of severe neurological dysfunction. And surgery will pose potentially the best outcome in dogs with high-grade spinal cord disease, so mainly non-ambulatory dogs or dogs who don't respond to conservative management. When we talk about intervertebral disc extrusion, it is crucial to bear in mind this condition, progressive ascending and descending myelomalacia. This is an irreversible softening of the spinal cord parenchyma that happens in dogs with severe spinal cord injury, so normally in dogs grade 5, plegic without nociception. As I said, this is irreversible, progressive, and catastrophic and life-threatening, requiring euthanasia in the vast majority of the cases. So it's not a common condition. It only happens in 2% of the whole population of dogs with intervertebral disc extrusion. And so basically, clinically, these dogs are dogs with a grade 5 spinal cord disease that develop new deficits of spinal reflexes, for example, in the pelvic limbs or in the perineal reflex. We have a cranial traveling of the cutaneous trunci reflex. We may have flaccid abdominal muscles, Horner syndrome, even thoracic limb deficits, unspecific pain, pyrexia, difficulty to keep external recumbence, and respiratory failure. So as I said, it is uncommon, only 2% of the whole amount of dogs that will have acute spinal cord compression due to disc extrusion, but it may be a bit more likely if we, as I said, talk about dogs with grade 5 myelopathy. As you can see, the percentage increases a lot. It's a bit more common when we have a rapid neurological deterioration, so having a dog that within just a matter of a 12 to 24 hours period, they go from ambulatory to non-ambulatory or even paraplegic. French bulldogs seem to be a bit more represented with this disease, and it happens a bit more often when we have mid to caudal lumbar discs, so basically compressing the lumbar intumescence. Normally, the onset of clinical signs of this condition of myelomalacia happen in this window from 2 to 5 days after the onset of the neurological deficit, although we may have delayed presentation. So, talking about prognosis, and as you remember this grade that we said before, from 1 to 5, as you can see, the main kind of cutoff is feeling pain or not feeling pain. If we have a dog that has nociception, success rate is as high as 97 or even 93%. However, chances drop significantly, almost 30%, when we have dogs that do not feel or do not perceive pain. Hence why it's very important, especially when we have paraplegic dogs, to assess pain perception. Intervertebral disc protrusion. So this consists of a fibroid metaplasia of the disc and progressive thickening of the dorsal annulus fibrosus, which ends up protruding dorsally into the vertebral canal. It typically happens in non-chondrodystrophic breeds over the age of 7 years, suggesting that this type of disc degeneration represents a consequence of later onset age-related changes in comparison to chondrodystrophic dogs. Considering the age group that we're dealing with, simple imaging may be useful to rule out other differential diagnoses with similar clinical presentations such as spinal neoplasia or osteoarthritis. Again, we're talking about aged dogs, so performing blood work, urine analysis may be recommended to check for diseases commonly seen in senior dogs like chronic kidney disease, endocrinopathy, systemic hypertension, etc. So normally these dogs will have a clinical history being chronic, slowly progressive, and long-standing, although we may have some acute on chronic presentations. Treatment can be conservative, which will consist in moderate exercise restriction, instigating multimodal analgesia, and these can include non-steroidal anti-inflammatories, gabapentin, paracetamol, and other pain relief. In these cases, considering a holistic approach may be recommended, and they will definitely benefit, many of them, from hydrotherapy and physiotherapy and potentially other alternative medicine approaches. Surgical treatment is an option, and it's an option in dogs with high grade of myelopathy, so basically non-ambulatory or severely paraparetic dogs, and in cases in which conservative management fails. But we need to be aware that the goal of spinal surgery in cases of chronic disc protrusions must be different, to start with, to cases of acute disc extrusion, because sometimes a full recovery may not be achieved, and it is common to see a temporary postoperative neurological deterioration in these cases. Acute non-compressive nucleus pulposus extrusion. This is an extrusion of healthy, hence hydrated, nucleus pulposus material through the annulus fibrosus, which is ruptured. It causes spinal cord contusion with minimal or with no spinal cord compression. Since the disc material is not degenerated, this condition is more common in non-chondrodystrophic breeds. Cats may also be affected by this disease with the same clinical presentation, and the clinical presentation is basically a per-acute onset of signs of spinal cord disease. Normally, it is associated with vigorous exercise and trauma. We normally see often high grades, so dogs with severe para, mono, or tetraparesis. It tends not to be painful after 1 to 3 days of the onset of the clinical signs, and many times the neurological deficits will be asymmetric. Although a presumed diagnosis is achieved with advanced imaging, with MRI, simple imaging like radiographs will help rule out causes of traumatic spinal injury like vertebral luxations and fractures. And this is particularly important because, as I just highlighted, the onset is normally linked with trauma. It is important, where possible, to achieve a diagnosis because the type of management may be different from other causes of acute spinal cord injury, like vascular events that we will see shortly. So, in cases of acute non-compressive nucleus pulposus extrusion, rest is essential because the annulus fibrosus, as I said, is ruptured. So, intense physio or hydrotherapy may promote further nucleus pulposus extrusion, eventually, potentially, resulting in spinal cord compression. The treatment in these cases is then conservative. This is not a surgical disease, and this conservative management consists of strict cage rest, multimodal analgesia, maybe just for a short period of time, only the first few days. Bladder management in many cases is essential, and as I said, gentle hydrotherapy and physiotherapy. The prognosis to return to ambulation is generally good, but in cases of plegia with no nociception, combined with certain MRI findings of severe spinal cord injury, these are associated with a much poorer outcome. It is not uncommon in these cases to see long-term urinary and fecal incontinence. Fibrocartilaginous embolic myelopathy, or FCE. In this disease, the embolizing material is fibrocartilage from the nucleus pulposus of the intervertebral disc, which may enter the vascular bed that supplies the spinal cord and acts as a clot or as an embolus. Non-chondrodystrophic breeds, especially miniature schnauzers, are predisposed. The presentation is very similar to the acute non-compressive disc extrusion, so it's per-acute. It tends to be as well associated to physical activity, Often we see high grades of myelopathy, and this disease is not painful. It is very common as well to see an asymmetry of the neurological deficits. MRI is required to achieve a diagnosis, and in cases like this, exercise restriction is not required. On the contrary, early rehabilitation helps with recovery. So, again, the treatment is basically providing these dogs with nursing care, physio or hydrotherapy, intense bladder management in some of them, and again, pain relief is not required. The outcome is generally good in the vast majority of the cases, although we need to be aware that it may be guarded to poor in large breed dogs with severe neurological dysfunction. Feline ischemic myelopathy. This is a similar condition to the canine counterpart. The presentation is the same, so per acute onset of clinical signs. It's especially common in old to geriatric cats, and there is a predilection for the cervical spinal cord segments. In a relatively high proportion of the cases, we may find an underlying disease, and these are commonly chronic kidney disease, hypertension, hyperthyroidism, and heart disease. The treatment is the same than in dogs, but if an underlying disease is found, this should be addressed accordingly. The outcome is generally good in the majority of the cases. Feline aortic thromboembolism. The presentation is also per acute, and it's basically pelvic limb dysfunction. In this case, though, we may see a hyperesthetic area at the level of the pelvic limbs, we may find as well, very commonly, very weak or even absent femoral pulses. The limbs will be cold, and the nail beds and paws will likely be cyanotic due to the hypoperfusion. Frequently, we will find an underlying heart disease, which in cats will commonly be hypertrophic cardiomyopathy. Normally, the thromboembolism will get lodged at the level of the aortic trifurcation, so performing an abdominal ultrasound and echocardiography will be advised. The treatment will consist in addressing the cardiopathy, instigating antiplatelet and thrombolytic therapy, pain relief, physiotherapy, and bladder management. However, we need to be aware that the outcome tends to be poor and relapses are frequent. Traumatic spinal cord injury. This normally happens as a result of road traffic accidents, fights, falls, and bites. Consequently, we may come across vertebral subluxations and fractures. We should take into consideration that not only the spinal cord or the brain are important, but also other organs, as many of these cases will have other organ or cavities involvement. For this reason, a comprehensive, holistic approach should be done. First of all, using the ABC system, so ensuring adequate airway, breathing, and circulation. And then checking, as I said, other concurrent problems like limb fractures, hemoabdomen, or pneumothorax. In these cases, the handling of the patient should be really careful, and we may have to use chemical restraint. Simple imaging may be adequate in the vast majority of the cases, but it is very important that we take two views, as we can miss really important findings. Conservative management may be considered in these cases if the neurological dysfunction is mild, if there is not a lot of discomfort, or if the displacement of the vertebral fracture or subluxation is minimal. Analgesia will be required, and very importantly, strict cage rest and limiting the movement of the spine, in this case using a splint, a brace, or a cast. A nursing care will be essential. Surgery is necessary in some cases, and in order to assess the stability of the spine, the three-column system should be used. So, the dorsal column consists of the lamina, the spinous process, and their associated ligaments. The middle column consists of the dorsal longitudinal ligament, the dorsal annulus, and the dorsal cortex of the vertebral bodies, and the ventral column is the ventral longitudinal ligament, the ventral annulus fibrosus, and the ventral cortex of the vertebral bodies. So if two or more of these columns are disrupted, then there is instability. Hence, surgery is required. The aims of the surgery is to reduce and stabilize the fracture. We need to be aware that in cases of spinal cord involvement with fracture or with subluxation, and if dogs or cats have a grade 5 myelopathy, so plegia without nociception, the success rate, even with surgery, is lower than 5%. So finally, and to summarize, please use clinical reasoning. Common things are common, and having knowledge of diseases for each group, species, and breed will help us. These are essential data to consider because we will not approach in the same way an old cat with paraplegia and cold legs than a middle-aged dachshund with paraparesis or a very young beagle with neck pain. And lastly, and please bear that in mind, as you have seen, not all spines are surgical. Please, if you have any question, any query, any doubt, we will be very happy if you send us an email. Use this email address and we will get back to you as soon as we can. Thank you very much.